got our learning objectives. So the first one being we're reviewing effective lipid management for patients. We are focusing on the NICE guidelines itself about non-HDL and high intensity statin therapy. We want to extend knowledge around primary prevention in terms of risk and apply the actual NICE endorsed national guidance for lipid management for primary and secondary prevention. So looking at the burden of CVD overall, I think there's no surprises for most people who join us here. So we are here to improve the whole CVD unmet need. And while the program looks specifically at cholesterol, treatment of the patient as a whole and taking a combined approach to AF, blood pressure and cholesterol is of vital importance. I think some of the figures on here are quite staggering. We really do see a huge number of deaths, a significant amount of which are premature from cardiovascular disease, and cholesterol has an enormous role to play in that arena. So it's important that we address this in line with other risk factors too, and prevent conditions like heart attack, strokes and vascular dementia cases, which we are seeing increase year on year. So better cholesterol management is directly related to better outcomes for our patients. So this is underpinned by a robust evidence base. As you can see here, we're looking at about 25 to 28% of CVD deaths are due to elevated cholesterol. And it's the second most significant medical risk factor after blood pressure. This seems to be sort of widely misunderstood or underreported. And what we want to do is ensure that cholesterol gets the attention that it needs in order to save those lives and ensure that people live a better quality of life.
Thank you very much. So first we're going to focus on updates to the guidance and what it means for us in practice. I always feel that cholesterol has been a bit of a Cinderella clinical condition compared to other areas of cardiovascular disease, having worked in CVD and CVD prevention for the past 20 years. So I'm really pleased to see this focus that we've got, coordinated focus on improving lipid management to improve patient outcome over the next few months and years. So the things that we will focus on today is cardiovascular risk and the importance of establishing cardiovascular risk and communicating that to patients. We actually had our first webinar focusing on this, so we'll touch on the basics, but we won't be looking at that in huge amounts of detail. We'll talk about the relevance of non-HDL cholesterol to assess cardiovascular risk and how we would use it in practice. And we'll talk about high intensity statin therapy and high dose high intensity statin therapy and what that would mean for the patient. So just a reminder really that we have sort of 4 pillars of NICE. Pillar 1 around the technology appraisals, and we've had numerous technology appraisals for drugs related to lipid management. We have the guideline recommendations, which is what we're focusing on today. Probably the thing we struggle with most within the NHS is ensuring that we have effectively implemented these guidance to maximize their impact, and obviously a pillar around leadership data and research to make sure we're pushing the agenda and the outcomes for patients forward. So first of all, thinking about risk assessment, NICE in the 2014 guidance recommended that we should use a systematic strategy to sort of pre-screen patients based on the information we already have on them within the GP system. So you can actually estimate what their risk might look like before undertaking a formal assessment based on what's already documented within the GP record. And then you can prioritise people for full formal risk assessment if their risk is already estimated to be above 10%. That means the return on investment for that early intervention will be greater. Clearly, we also need to ensure we're regularly re-reviewing the risk for these patients because it will change over time. With the NHS health check starting risk assessments at around 40 years old, clearly the risk will change in the 50s, 60s, 70s, so we need to keep undertaking that risk assessment. NICE recommended QRIS 2. We have obviously seen an iteration QRIS 3 since then, and that currently hasn't been formally endorsed by NICE, and QRIS 2 can still be accessed. I think the thing that's most important about using QRIS 2 is making sure you're using it in the right patient cohort. So you can't use it in those who are over 85, but it should also not be used in patients who have suspected or confirmed familial hypercholesterolemia, because it will significantly underestimate their risk. Patients with type 1 diabetes, those with pre-existing cardiovascular disease of any form, and those with chronic kidney disease, stage 3 or more. And QRIS can be easily accessed online, but it's pretty much embedded in the GP systems as well. Beyond that, there are some tools that can help primary care to undertake risk assessment, identify patients who may be at risk of familial hypercholesterolemia, and also those that may be suboptimally managed in relation to their cardiovascular risk. And these are fully integrated with EMIS and with System 1. So some of the tools that are available are the CDRC Precision tool, the Primus FAMCAT tool for FH, and the UCLP Proactive Care Frameworks. And if you want more information on those, we can provide that through the Q&A or after the meeting today. Really important that we don't forget to exclude or manage secondary causes of hyperlipidemia before we start worrying about treating cholesterol. So type 2 diabetes, CKD we've talked about, hypothyroidism, medicines that might change lipid profiles, obesity, an increasing issue within our population, and post-lockdown, excessive alcohol consumption, probably also an increasing issue. We've probably all seen that in the news. And we mustn't forget, when we focus quite heavily on drug therapy and the nuances of drug therapy, that there are lots of things people can do to reduce their risk through addressing lifestyle issues, and these only complement drug therapy. So reducing alcohol intake, modifying diet, increasing physical activity, losing weight if patients are overweight or obese, and smoking cessation, all essential interventions alongside some of the medical interventions we might also recommend. So over the last few years, we have accrued a data set that shows that if we can drive LDL down low enough, we can move from just reducing individual cardiovascular events to actually promoting regression of the atherosclerotic plaque within the coronary artery. And we will hear more about this from Dermot, because he's going to focus more on the secondary prevention strategies. But ideally, we wouldn't let our patients get to the point that you can see in diagram C with a very significant atheroma. And if we intervene earlier, we might not need to intervene with such high intensity in terms of primary prevention, because we're preventing the buildup of that plaque at a much earlier age, which is the key premise really of primary prevention. With this in mind, that the lower we can drive the LDL, the greater chance we have of delivering regression. Really what we want to look at is statin therapies that reduce cholesterol significantly, and the target that NICE put in the guidance back in 2014 was that we should use what they termed as high intensity statins, and this will deliver an LDL-C reduction of 40% or more. So you can see the statins that we have on the market in the UK, fluvastatin, pravastatin, getting nowhere near to that high intensity lipid lowering that we're looking for. Simvastatin, even at the 40 milligram dose, is below that threshold. The higher dose, the 80 milligram of Simva, does achieve high intensity, but is not routinely used because of the risk of the increased risk of adverse effects with that dose. So really, we're talking about atorvastatin at a dose of 20 to 80 milligrams, which is what was initially recommended by NICE, but also rosuvastatin across the dose range, apart from the 5 milligram dose. Now, atorva was preferred at the time that the guidance was published, because rosuva was still a patented drug, but clearly both can deliver that high intensity drop in LDL-C. And we also have the addition of ezetimibe on top of statin therapy, adding to the potency of LDL lowering, increasing the effectiveness of atorvastatin up to 61% LDL reduction in combination with ezetimibe. So those are the doses and the drugs that we really should be focusing on across the board, regardless of whether you're talking about primary and secondary prevention. But we will talk about when you use the higher doses of the high intensity statins and when you would start with the lower doses. So I often get asked, well, does it matter? Does it really matter if you incrementally increase the statin dose in terms of outcomes for patients? Often people have seen data for acute coronary syndrome, but there's data that treating more aggressively in stable coronary heart disease also improves patient outcome. So you can see here the impact of 80 milligrams of atorva versus 10 milligrams of atorva in patients with stable coronary heart disease, and it impacts on major cardiovascular events, non-fatal MI or death from CHD, and also from stroke or major coronary events. All of them show a significant reduction in the risk of events with the higher dose of atorvastatin. But we're only going to get the benefits of statin, high intensity statin treatment, if we can support our patients to adhere to therapy. So there is, robust data that shows that the more non-adherent your patient is, the poorer the outcomes for them in terms of the impact of statin. It's kind of obvious, really. If patients aren't taking the medicine, then they're not going to get the benefits. These are long-term drugs to reduce cardiovascular risk over months and years, not over days and weeks. So long-term adherence and persistence to therapy is really key. And in order to do that, we obviously need to support our patients right from the beginning of therapy, including ensuring we're making a shared decision with them. So we do have nice guidance on how to make a shared decision. Really, it's about offering patients the information they need and supporting them to think through what would best meet their needs, taking into account their individual preferences, beliefs and values. Really important that patients understand the benefits and the risks of the different options they have, and have an opportunity to really explore any concerns that they may have about the treatment plan that they are making decisions about. There are resources that we can use to help support people so they understand the benefits. There's two different ways of expressing this data in the next couple of slides. So this shows you that if 100 people take atorvastatin at the recommended dose for 10 years, most of those will not have an event. But with atorvastatin, compared to no treatment, we will prevent 4 events. Unfortunately, we won't be able to prevent events in 6 people. The challenge, of course, for us is if we could target our therapy more accurately and identify those 4 that we could protect, we could just treat them. But at the moment, we have no way to determine which of the 100 are likely to go on to have an event. So we have to treat them all in order to protect the 4. And this is the same data, just expressed in a slightly different way with what you may have seen before, the smiley faces. And this comes directly from the NICE patient decision aid and is available for use in clinical practice. So again, without treatment, 90 out of 100 people will be fine, 10 out of 100 people will develop coronary heart disease or have a stroke, represented by the red faces. With treatment with atorvastatin for 10 years, this is for prime prevention, you will prevent 4 of those 10 events. But we have to treat the 100 to protect the 4 because we can't identify those up front. Another change that came in within the NICE guidance was around the use of non-HDL versus LDL cholesterol. So previously, we'd only ever really referred to LDL cholesterol and had some targets around, well, what should we be aiming for in terms of LDL cholesterol? But this guidance from 2014 for the first time recommended non-HDL levels for monitoring risk. And it's really a pragmatic decision about the practical issues with using LDL routinely. So in terms of LDL, you can either measure it directly, but it's a very expensive test that has not been used in routine clinical practice. Or what we actually did was calculate LDL using a formula. And that formula was based on the triglyceride and HDL concentrations that were measured, and they were used to calculate the LDL. The problem with this is you need a fasting blood sample, which is inconvenient for patients. It can underestimate LDL-C at low levels, and triglyceride levels are very heavily affected by food, and there are quite marked deviations in the outcome in terms of the LDL calculations if patients already have raised triglyceride levels. So NICE recommended a move to non-HDL cholesterol. So I'm just going to go on now to just focus on prime prevention and the treatment of patients guided by their cardiovascular risk. So this is the NHS E and A Accelerated Access Collaborative summary of the National Guidance for Lipid Management, which has been endorsed by NICE, recently been updated to include bempedoic acid, because that had a NICE technology appraisal back in April. We're going to focus on the left-hand side of this chart, which is the prime prevention element in green. Just to highlight that on the back of the algorithm, there's also a huge amount of really useful information in relation to lipid management around, as you've seen already, the high intensity statin data, when you might need specialist services, how to manage high triglycerides, and issues around monitoring, etc. So I would encourage you to have a look at this document, because it pretty much includes everything you would need to manage your primary and second prevention patients effectively, and also FH. As I've said, because we're now using non-HDL cholesterol, you don't need to do a fasting sample. You can do a non-fasting lipid profile. And obviously we also need to look at blood glucose, so HbA1c as part of the assessment. Consider secondary causes and manage those as appropriate. Make sure that you're looking at all the other baseline and follow-up tests that are included in the guidance. Other issues that might impact on your treatment decision, including contraindications to drug therapy and drug interactions. And if the non-fasting triglyceride is above 4.5, you might need to make interventions around that. So for prime prevention, we have 5 key categories. We tend to focus on Q risk assessment, and certainly in those aged less than 84, or sorry, less than 85, we should be doing Q risk assessment and thinking about intervention where the Q risk score is greater than or equal to 10%. Similarly, for patients with type 2 diabetes. For type 1, we're looking for other risk factors, looking at age, duration of diabetes, renal function, and other CVD risk factors which would mandate intervention. CKD, as I've talked about, stage 3 or more are not appropriate for Q risk, but would also require intervention. And for those who are over 85, we should consider intervention, but take into account their comorbidities, frailty, and life expectancy. So NICE were keen to emphasise that even in those aged over 85, the addition of statin therapy for prime prevention does reduce non-fatal myocardial infarction. So for all of these patients in prime prevention, the first step is looking at all the other modifiable risk factors. So smoking, diet, obesity, alcohol, physical activity, their blood pressure, and HbA1c, and doing everything we can to reduce those risk factors. And going on from that, thinking about any other things that might impact on their cardiovascular risk and need addressing. Once you've addressed all the modifiable risk factors, the question is, what's the next step? Just a reminder, I think, coming up about the dosing. Atorva, 20 milligram, 43% average drop in LDL, going up to 55% as we go up to the 80 milligram dose. And you can see similar across the dose range for rosuvastatin starting at 10 milligram. So finally, we need to consider, what do we do with patients who have side effects, and those that, and there is a whole statin intolerance pathway for you to follow, also available through the Accelerated Access Collaborative. If the maximum dose of statin, so if you've up-titrated the patient for prime prevention to Atorva 80 and the non-HDL-C has not reduced by more than 40%, there's the option to consider adding ezetimibe in that point. It's also recommended if statin therapy is contraindicated or not tolerated. And if at that point you still haven't got the lowering you require, which is the 40% drop from baseline, that's the time to consider asking for support. That might be through advice and guidance or by referral from the local specialist lipid clinic. And I'm going to hand over now to Dr. Dermot Neely to talk about secondary prevention.
Thank you very much, Helen. That was a very comprehensive overview of our pathway for primary prevention steps. And I'm just going to follow on from that. I'm going to talk mainly about secondary prevention, but I'm also going to touch a little bit finally on the statin intolerance pathway and familial hypercholesterolemia as an alternative situation to deal with under the pathways. So firstly, a little bit about the scope of the pathway. You've had an overview of this already. We'll walk through secondary prevention, and then, as I say, that will naturally lead us on to those exceptional patients where you're not able to manage them effectively with the NICE recommended therapy and need to think about statin intolerance strategies. So again, just returning to the overview of these pathways, which are a summary of NICE guidance, which has been distilled down to a series of steps. It's an algorithmic approach, which will give you a logical structure for identifying the correct dose for your patient, for their circumstances, and how that should be monitored, followed up, adjusted, and ultimately the goals achieved. Now, all of this guidance from NICE is largely based on randomized controlled trial data, which is based on hard outcomes, cardiovascular events, which have consistently shown that patients treated with high intensity statin doses actually have fewer cardiovascular events than those treated with moderate intensity or low intensity statins that were the original statins that were discovered and brought into clinical practice nearly 3 decades ago. Now, this is based on intravascular ultrasound studies where different doses of statins were compared, and the effect of those doses on the volume of atheroma was actually studied. And what this has shown in this meta-regression analysis is that if you're able to achieve on treatment LDL cholesterol down below about 1.8 millimole per liter compared to above, more of those patients were exhibiting a reduction in the volume of their atheroma compared to an increase in the volume of their atheroma if they went to a higher LDL. So this isn't necessarily going to convert a patient who's had a cardiovascular event represented by the C diagram at the top into somebody who's more resembling the B, but it will actually prevent them progressing to the same extent, and that will translate into reduced cardiovascular events. Now, broadly speaking, for the average patient, if we do achieve the 40% reduction of non-HDL cholesterol, we will get them into the low range that's consistent with the likelihood of more regression rather than progression. Here we have the steps in the pathway that are set out for patients with for secondary prevention. Now, these patients may have stable cardiovascular disease or they may have a recent acute coronary syndrome. But regardless of which they have, it's recommended that a baseline sample for lipid profile is taken and that they should be commenced on a high intensity statin without any unnecessary delay. Now, we recognize that in patients admitted to hospital with an acute event, the tissue injury will cause the cholesterol to fall after about 24 hours. So it's important that a sample is taken on admission to get a baseline value. And we know this doesn't always occur, but it's important to do that where possible. Now, again, for patients, whether it's for primary prevention or secondary prevention, it's always important to identify and address those modifiable risk factors: smoking, diet, obesity, alcohol intake, physical activity when they've recovered, and of course, blood pressure and diabetes control. These are all important, and they're part of a holistic approach to risk factor management in patients with pre-existing cardiovascular disease. But there should not be a delay to starting statin treatment for secondary prevention while you're managing these modifiable risk factors. It's important that the earliest opportunity to start a high intensity statin. For most coronary care units and stroke units in the country these days, people are starting atorvastatin 80 milligrams on the day that they're admitted to hospital. And that has actually been shown, particularly for coronary events, to reduce the number of events occurring in those patients within a month of the onset of the event. So it's really important to get on and get them on treatment. Now, there may be circumstances where 80 milligrams of atorvastatin maybe should be changed to a lower dose, and particularly those patients who may have reduced renal function, but maybe where they're on other drugs that might interact, or there's a concern about previous problems with adverse effects, or indeed patient preference. Now, it's very important that we have appropriate follow-up of patients once they have been commenced on treatment. Now, for somebody who's had a myocardial infarction, we'd expect the cholesterol to return to the pre-event levels by about 3 months. So it's reasonable to recheck a lipid profile after 3 months to ensure that you've actually achieved the amount of cholesterol lowering that we're looking for. And this, as Helen said, can be done on non-fasting blood sample with a measurement of non-HDL cholesterol. And you should be expecting to achieve at least a 40% reduction of non-HDL cholesterol from baseline. And if that's not been achieved, again, we can't emphasize enough to have the discussion with the patient about whether they're taking the tablets, what time they're taking them. And indeed, it may be that telling people to take them at night may lead them to miss a tablet, and it could be for long-acting statins such as atorvastatin, it's reasonable to take them in the morning with all the other tablets that they might be taking. Diet and lifestyle measures as well are quite important. If the patient has gained weight, you may expect that that'll offset the effect of the statin. But if the patient has been started on a lower dose than 80 milligrams, that could be increased if possible. And if the non-HDL cholesterol target of less than 40% cannot be calculated because there's no baseline value, we do have this alternative target of a non-HDL less than 2.5 millimoles per liter, which is approximately equivalent to less than 1.8 LDL cholesterol. And this was the target recommended by the Joint British Societies. It actually corresponds to, roughly speaking, what you'd expect to see in the average patient with a 40% reduction, which we'll see shortly. If the patient in a high-intensity statin has side effects, it's perfectly reasonable to offer that patient a lower dose or an alternative statin, such as rosuvastatin. In many cases, may be tolerated by a patient where atorvastatin has not been tolerated. So we do have options, and this is important. Once you have achieved the maximum tolerated dose of a statin, if the non-HDL cholesterol has not fallen by 40%, we can look at ezetimibe according to NICE technology appraisal 385. And it's actually possible to achieve a greater increase in the non-HDL reduction with the addition of ezetimibe than it is with the doubling of the statin dose. So addition of ezetimibe is a very good option in patients where you're struggling to achieve adequate control, and the patient may be limited in the dose of atorvastatin or rosuvastatin they can take due to some adverse effect or other. If the recommended statin therapy can't be tolerated or is contraindicated, well, we have a statin intolerance algorithm, and we'll deal with that in a subsequent webinar. Think about ezetimibe. Initially, you may restore confidence in the patient by starting them on ezetimibe monotherapy and then titrating back with smaller doses of a statin. And we do the new option now of ezetimibe combined with bempedoic acid in patients who can't tolerate a statin in the recommended dose. And interestingly, NICE have said that it doesn't mean you have to abandon a lower dose of a statin that they could tolerate to be able to use this combination. If the non-HDL cholesterol remains very high, that's above 4 millimole per liter, despite all these efforts, we do for secondary prevention patients, and indeed for some FH patients, have the option of considering a PCSK9 inhibitor. Now that's going to require a fasting blood test to get an LDL cholesterol measurement to see if they're eligible. There is a little guide on the back of the pathway just to tell you what the thresholds for those PCSK9 inhibitors are, evolocumab and alirocumab. So once again, just the overview of the front, and if you turn over to the back on the next slide, please, you'll see what Helen has shown you already, which is the additional supporting information that will help guide these various decisions, and in particular the statin intensity table. We've already talked about the classification of statins according to the NICE intensity table, and those blocks in blue represent a high intensity combination of statin and dose that should give us the results we're after. I think it's a reasonable thing to share this with patients so they can see you know, what you're trying to do and how the different doses and combinations such as ezetimibe and a statin could be used to achieve the same thing. But it's also important to understand the relationship between the LDL reduction and the non-HDL reduction. I know that sometimes people find this a little bit confusing. So as mentioned already by Helen, non-HDL cholesterol is easily calculated as the total minus the HDL cholesterol from a non-fasting sample. LDL, on the other hand, does require a fasting sample, and LDL is calculated by subtracting the VLDL cholesterol contribution, which is calculated from the fasting triglyceride divided by 2.2. It's important to recognize that when you start people on statin treatment, HDL cholesterol is barely affected. Triglyceride concentration in the fasting state is also barely affected. In fact, it's more likely to be affected by lifestyle measures than statins. So if the HDL cholesterol does not change, the reduction in non-HDL cholesterol is actually reflected in the reduction in the LDL cholesterol. And when the triglycerides remain the same as well, you can equate the reduction in non-HDL cholesterol to LDL-C. So we can see this from this example. So on the left-hand side of this slide, you've got a patient with a total cholesterol of 5. The HDL is 1.2. The non-HDL cholesterol is 5 minus 1.2, which is 3.8. And that's made up of 3 millimoles of LDL cholesterol and 0.8 from VLDL cholesterol, which is in fact the calculated value from triglyceride of 1.7 fasting divided by 2.2. Now on treatment, if there is a 1 millimole per liter reduction in non-HDL cholesterol, this will be largely due to uptake of LDL cholesterol through the receptor-mediated upregulation you see with statins. So the LDL cholesterol reduces from 3 to 2, the non-HDL from 3.8 to 2.8, and the total cholesterol from 5.0 to 4.0. So as you can see here, a 1 millimole per liter reduction in LDL cholesterol gives you the same reduction in non-HDL cholesterol and total cholesterol. Now clearly the percentage reductions are changing here in the sense that 1 millimole per liter of your LDL cholesterol is a 33% reduction, whereas it's only a 20% reduction in non-HDL cholesterol and only a 20% reduction in total cholesterol. If you just flick to the next little additional box on the next slide, we can see that in this case, the 26% reduction in non-HDL cholesterol is less than we wanted. If we want a 40% reduction in non-HDL cholesterol, we want that non-HDL taken from 3.8 down to 2.3, which is going to give us a reduction in our LDL from 3.0 to 1.5. So the non-HDL reduction of 40% is actually a 50% reduction in LDL cholesterol. But the important thing to recognize here, you're getting 1 millimole per liter or 1.5 millimole per liter of bad cholesterol taken out of the system. And you can monitor that with non-HDL cholesterol just as well as you can with an LDL cholesterol, except that the non-HDL cholesterol is better, if you like, more reliable and can be done on a non-fasting sample. So important thing to recognize is that the bad cholesterol, the non-HDL cholesterol, is an easy way to monitor progress with statin therapy. The treatment and titration targets and thresholds are actually summarized in the small table on the back. And as you can see here, we've said that you should be intensifying lipid-lowering therapy to get a non-HDL reduction from baseline if it's of at least 40%, and the equivalent target for FH is actually from an earlier guideline, CG181, which puts this in the terms of a 50% reduction in LDL cholesterol. Actually, there's probably not much difference in these standards, in fact, because non-HDL cholesterol and LDL cholesterol are calculated from different starting values. The Joint British Societies 3 does provide us with this useful benchmark alternative where you don't have the baseline, and we're happy that if you use this, you will actually, roughly speaking, be able to achieve the same sort of standard of treatment that you would do with the baseline calculation. Go to the next slide. So this little paragraph has changed in the new guidance, and it just recognizes if statin therapy is contraindicated, not tolerated, or not effective, consider first ezetimibe, then ezetimibe bempedoic acid, and then PCSK9 inhibitors. The use of ezetimibe bempedoic acid is not precluded when a prior low-dose statin therapy is used due to intolerance to high-intensity statin therapy, but you must ensure to look at the summary of product characteristics for the individual statin to make, and for bempedoic acid, to make sure there's no interactions. Other drug therapies that have previously been used to lower cholesterol were actually discouraged by the NICE guidance back in 2014. So don't use fibrates, nicotinic acid, bile acid binders, or omega-3 fatty acids unless that's under specialist supervision. So here's just a few points to observe about the other statins and ezetimibe. So rosuvastatin is actually a very good drug. It's actually lost its patent now, so it's a generic therapy. It wasn't a generic therapy, it was still a branded drug back in 2014 when the CG181 was published, but it can be very valuable and sometimes is better tolerated than atorvastatin in certain patients. But it's we should avoid the use of any other statins other than rosuvastatin and atorvastatin because they're less effective and less well tolerated. Ezetimibe is a very well tolerated drug. And it's important to recognize that if you add ezetimibe to a low dose of a statin, you will get a bigger reduction in your non-HDL cholesterol than by the doubling of the dose of the statin, which is only about 6% per doubling, whereas ezetimibe you're going to reduce by 15 to 20% with the addition. Now, PCSK9 inhibitors, where they can be used, the patient is eligible, can be added to statin and ezetimibe combinations and will give you a further reduction in HDL, LDL of approximately 50%, sometimes greater, sometimes a bit less. It depends on the individual patient. And for a comparison, bempedoic acid combined with ezetimibe will give you an additional approximately 28% reduction in LDL. Now, at the moment, we're recommending that this is specifically should really be considered carefully in patients who particularly have got high risk, as in secondary prevention. It is approved by NICE for primary prevention, but we'd encourage people to go through the statin intolerance pathway in such patients. This is just a brief mention of monitoring. So monitoring arrangements are based on including liver profile at baseline, a repeat at follow-up. We know that liver enzyme abnormalities are actually relatively common in patients on no therapy at all due to obesity and other factors, and rarely do statins cause hepatic toxicity, but it's important to check for that after each dose titration at approximately 3 months and then at 12 months of therapy. And beyond that, it all should be required as a lipid profile just to make sure people are adhering to their therapy and continuing to get the benefit. Statin intolerance, as mentioned, is variously defined. NICE has actually said that this is where treatment statin treatment is considered represent an unacceptable risk to the patient, resulting in adherence to therapy being compromised. Now, there are many other definitions, but this is the definition NICE uses. So if total cholesterol is greater than 7.5 or LDL greater than 4.9 or non-HDL greater than 5.9, please consider the possibility that your patient might in fact have familial hypercholesterolemia. And it's not appropriate to use the Q-risk assessment tool in these people because there's very few people of this type actually in the Q-risk database for valid comparisons. So in these people, a fasting blood test is required to measure LDL cholesterol accurately, and then you can apply the Simon-Broom or the Dutch Lipid Clinic criteria to make a clinical diagnosis. If a clinical diagnosis is made, we currently recommend that patient's referred to a lipid clinic for further assessment and to be offered a genetic test. And even if there is no family history and you cannot make a diagnosis according to these criteria, if their total cholesterol is greater than 9, LDL greater than 6.5 or non-HDL greater than 77.5 or TGs greater than 10, those patients, again, according to CG181, should be referred to a lipid clinic for further assessment. Treatment targets we've already touched on, being a 50% reduction in LDL. I'm quite happy to monitor non-HDL and look for a 50% reduction, given that there's a very low triglycerides usually in FH patients and the VLDL contribution is quite small. But there are certain situations where even in patients with an established diagnosis of FH, you may need to think about referral. You should consider specialist referral for treatment in consideration of a PCSK9 inhibitor if they're assessed to be at very high risk of a coronary event, or therapy is not tolerated, or if the LDL-C remains greater than 5 millimole per litre for primary prevention or 3.5 millimole per litre for secondary prevention, despite maximum tolerated statin and ezetimibe lipid-lowering therapy. So here's some pointers just as practical guidance for people whose cholesterol is not at target. First of all, optimize treatment if possible, using either an increasing, gradually increasing the dose of a statin that they do tolerate, or consider adding ezetimibe. If they appear to have statin intolerance, we've got a pathway to help investigate that. And we've got strategies such as an alternative statin or a reduced dose that can be used and take the pathway from there, but always aim to treat with the maximum tolerated statin dose. Finally, assess adherence. This is really important. We know that often patients don't take all prescribed medication, and we need to understand, what anxiety they may have around this. We've talked about shared decision making and bringing them on board and making decisions about their treatment, and actually making sure they understand the benefit that they're likely to get if they achieve the goals that we've set for them, and always to ensure that they make all efforts with healthy diet and lifestyle as well as medication. Finally, just to the take-home messages. Now, these are quite small print, but lipid management, we know, remains suboptimal in the UK, and we believe that if you use these pathways that we've developed in collaboration, have been endorsed by NICE, that the high-risk patients should be able to be effectively treated. I think shared decision making with our patients is a very valuable tool to try to help this, and we should take a holistic approach, not just focusing on one risk factor, but on all the cardiovascular risk factors the patient has. The NICE endorsed pathways are available to guide this, and it's important to recognize that most of the decisions for our patients can be made based on non-fasting samples measuring non-HDL cholesterol, with a few exceptions. for we need to measure LDL cholesterol, such as diagnosis of familial hypercholesterolemia and assessment of eligibility for PCSK9 inhibitors. You've got the alternative option of a non-HDL cholesterol target of less than 2.5 if you don't have a baseline value. And there are certain circumstances where we'd want you to consider specialist referral, either for a face-to-face appointment or for advice and guidance in patients who are statin intolerant or those people we think may have familial hypercholesterolemia. So I'll just hand over back to our chairperson on the next slide. Thank you.
So the most upvoted question from Sandra is, how long should a patient try a lifestyle modification before they are offered atorvastatin?
So yeah, I mean, I think this depends a little bit of whether you've got primary or secondary prevention situation. So primary prevention patient, I think you've got time. And I think that patients may be more convinced that they need a statin if they've gone away and made every effort to improve their cholesterol, reduce their weight, address all the other risk factors. And if they find that their cholesterol is unmoved by all those efforts at the end of the day or still above the intervention threshold, they may be more convinced of the need to go on a statin. And that's certainly been my experience. That could take 3 months. And I think if they're supported by a dietitian or nutritionist or some appropriate guidance for that, it'll give them an opportunity to go and give it their absolute best shot before the final decision about statin is made. For secondary prevention, I think it's important that the risk is such that early intervention with a statin seems to protect these patients from events, and they should be encouraged to make lifestyle changes in parallel. They're going to need a statin anyway, so there's no reason to delay.
Thank you. Question from Nikki Holdsworth. If a patient's been prescribed a suboptimal dose of the statin, for example, 20 milligrams, and the percentage effectiveness of increasing the dose, would it be a benefit to do a statin washout before you recommence on a higher and more appropriate dose?
No.
That was an easy one.
Yeah.
So no washout.
Well, the only reason for a washout of a statin is if somebody is actually intolerant or exhibiting symptoms of intolerance. I think if there's secondary prevention, you have to be careful in weighing up what's the likelihood that the symptoms are anything to do with the statin. For primary prevention, it's perfectly reasonable, and the statin intolerance pathway will advise you on a statin holiday if you're concerned that you're getting symptoms caused by the statin. And in that situation, you can prove this one way or the other by washing out with the statin, but there's no real benefit, in other circumstances if you're just adjusting therapy.
Question about HIV positive patients. So someone's been using Topo-Sobo, has been using QRISK-3 with HIV positive patients. Is that correct? It's taken into account? NICE haven't advised on QRISK-3's, if you like, adjustments for different risk factors. But what we do know that HIV seems to cause an endothelial injury, and that they get disproportionately increased cardiovascular disease at relatively low lipid values and other risk factors. So broadly, in most cases, it's a good idea to get an HIV positive patient actually on a statin, recognizing the potential for interactions with antiretroviral combination therapies. But no, I think that NICE at the moment haven't judged on QRISK-3. I think that'll be part of the next update.
I don't think HIV is one of the elements in it, having just Googled the score to double check. There are a lot of additional elements in QRISK-3, yeah, but I can't see HIV being one of them.
Okay.
Well, one that I think is interesting is someone was asking about, what if the cholesterol's normal and they've had an event, or their cholesterol's normal and but their QRISK is high? And I think it's important to recognise that we're treating their cardiovascular risk, not their cholesterol level. And all of these patients, even if you think the cholesterol's normal, if they've had an event or their QRISK is 10% or more, they should be on a statin, because that is going to lower their risk, along with all the other things that's driving the risk. So the importance of addressing all the global risk there, the blood pressure, the weight, the blood sugar, etc. But really important that we consider statins for CVD risk reduction. It's not all about the cholesterol level itself.
It's something that I addressed I answered a comment, just a typed answer to it earlier. And it was along the similar lines of, when you're talking about statins to patients, we often forget to actually remind them of the additional properties that they have. So whether it's things like plaque stabilization, for example, or along the lines of inflammation, we can talk about them about risk reduction and additional properties aside from just LDL, non-HDL lowering. Is really important, and I think it's something that I've heard through our helpline quite a lot, and through our helpline team, is that we get a lot of questions about people being prescribed statins when their cholesterol is not necessarily that high, but when they're told about the additional properties, it helps them to understand. So it's just a good note for clinicians who are prescribing, just to talk about those additional benefits.